My name is Lindsay Fensel, and I will be presenting today on nutrition intervention for chronic pain. The objectives we will go over today are registered dietitians and nutrition therapy counseling and how they can be productive parts of the chronic pain management team. You will see me utilizing CP as an abbreviation for chronic pain throughout this whole presentation. That is what's going to stand for moving forward. Physiological, lifestyle, and nutrition contributions. And there's 4 different ones like chronic inflammation, metabolic dysregulation and obesity, nutrient deficiencies, neurological hypersensitization, and then supporting research studies. There's 3 of them. Going into then evidence-based nutrition interventions that we can absolutely use as dietitians, going over a few take-home points, and then talking about future direction and clinical implications. Registered dietitian's scope of practice for chronic pain management is very important. Chronic pain is a multifactorial condition, and nutrition is one of the most modifiable and impactful factors for treatment and management of chronic pain, and a lot of different comorbidities and lifestyle diseases. A registered dietitian's tool for chronic pain management can include diet modifications, proper sleep hygiene, consistent exercise routines, proper hydration, stress management, individualized supplementation if needed, and then accountability and sustainable behavior change. So dietitians can do all these things and help you stay more accountable so that you can do things consistently enough over time to actually see the results. There are numerous reasons to talk about the importance of nutrition intervention. One of the biggest ones is how prevalent it is nowadays. 1 in 3 older adults, 65 years or older, and 1 in 5 adults between the ages of 18 and 65 struggle with chronic pain. I'm sure you know someone, whether it's including yourself or a family member or a friend, who has chronic pain. Chronic pain is associated with disability, reduced function, poorer quality of life, mental health challenges, less independence, and higher healthcare costs. It also has a huge socioeconomic impact, like increased healthcare costs, reduced productivity, absenteeism, and disability. So not only is it impacting the healthcare system, it's also impacting people within the workforce. Individuals with chronic pain often exhibit poor eating habits and metabolic function in general. So they'll generally have obesity, partake in excessive calorie intake, malnutrition, and have diets that are high in consumption of sugar, fat, sodium, and caffeine. There are various chronic pain conditions that are actually associated with nutritional factors. Many people just think of the basic musculoskeletal conditions, but there are so much more. So osteoarthritis, rheumatic arthritis, fibromyalgia, generalized lower back pain, irritable bowel syndrome, which would be the pain that's inside of your abdomen or your visceral cavity, associated with the organs of like your small intestine, your large intestines, your stomach, things like that. Endometriosis, pelvic floor pain, diabetic neuropathy, migraine headaches, post-hepatic neuralgia, and carpal tunnel syndrome. There are 4 large lifestyle and nutrition contributions to chronic pain that we will go over. Number 1 being chronic inflammation. Poor nutrition, which would be high in saturated and sugar intake, can increase pro-inflammatory cytokines and oxidative stress within the body, increasing chronic pain. Number 2 is metabolic dysregulation and obesity. Imbalances in glucose and lipid metabolism, often linked to obesity, can exacerbate systemic inflammation and chronic pain. Number 3 is nutrient deficiencies. Malnutrition and poor eating habits leading to nutrient deficiencies can contribute to the onset, progression, and outcomes of chronic pain. Number 4 being neurological hypersensitization. Diet can affect the nervous system sensitivity, which alters pain perception within the brain and exacerbates the experience of chronic pain. Number 1, chronic inflammation. Acute inflammation is a normal and natural part of the healing process, which we all know, but if prolonged past a normal healing period, it can become harmful and trigger chronic pain by releasing inflammatory chemicals that irritate tissues. Also, high levels of CRP, which is a blood marker that you can take to indicate chronic inflammation levels within the body, and cytokines have been associated with patients experiencing high levels of pain. So getting those blood levels can help you better understand if that patient has chronic inflammation. And then chronic inflammation can trigger central sensitization, increase pain sensitivity, while an anti-inflammatory diet may help calm the nervous system's response and decrease perceived pain. Obesity contributes to chronic pain through the following factors. Physical stressors, such as larger mechanical load, poor body mechanics and posture, and abnormal gait patterns. Inflammatory endocrine changes from excess adipose tissue or fat, reduced oxygenated blood flow to that local area that has the chronic pain, poor diet and inactive lifestyle habits, so not exercising, not getting a lot of activity throughout the whole day, decreased quality of life and ability to participate in activities of daily living, mental health and psychosocial distress, neurological changes leading to a lower pain threshold over time, which makes you experience pain at a higher level, poor sleep quality and obstructive sleep apnea, and then other associated metabolic conditions. Obesity is strongly bidirectionally linked to persistent pain across all age groups, not just older adults, everyone, with pain complaints increasing as BMI increases. So, unfortunately, if you have chronic pain, you will generally notice that obesity will correlate with that. On the opposite side, if you have obesity, you will notice that chronic pain correlates with that. So it's very bidirectionally linked together. Morbidly obese individuals are up to 4 times more likely to report pain, especially low back pain. Compared to individuals with normal body weight, those who are overweight report 20% more recurring pain, and those who are morbidly obese report 254% increase in chronic pain. Next, we get into number 3, nutrient deficiencies. Low levels of specific nutrients like vitamin D, omega-3 polyunsaturated unsaturated fatty acids, vitamin B12, magnesium, zinc, ferritin iron, selenium, and folic acid are commonly recognized within patients that have chronic pain. A poor nutritional status, such as malnutrition, unhealthy dietary behaviors, or suboptimal dietary intake, can play a significant role in the occurrence, development, and prognosis of chronic pain. Supplementing specific nutrients has been found to be helpful for improving chronic pain symptoms, especially for those who do not consume a colorful, balanced diet. So if you're not getting the proper nutrition and proper micronutrients through those fruits, vegetables, plant-based foods, taking additional supplementation like B12, vitamin D, omega-3 fatty acids, and fiber can be helpful. Lastly, fibromyalgia muscle pain has been associated with deficiencies in amino acids, magnesium, selenium, vitamins B and D. Essential amino acids are needed to produce neurotransmitters that regulate pain. Low intake of amino acids, especially tryptophan, can worsen chronic pain by decreasing serotonin levels and increasing nervous system sensitivity. Number 4 being neurological hypersensitization. Neural sensitization, triggered by injury or disease affecting the nervous system or body tissues, can lead to pain even when no structural damage is detectable. So why some people go to physical therapy for years and they have this low back pain or they have this knee pain and it's not getting better, but physical therapists unfortunately don't know what to do and doctors don't know what to do because structurally nothing really looks wrong. Various psychosocial and lifestyle factors can contribute to this neural sensitization, including adverse childhood experiences, emotional dysregulation, stress, unhelpful beliefs, social isolation, low physical activity, and poor eating habits. A diet low in saturated fat and added sugar can help reduce oxidative stress and peripheral inflammation, which limits vagal nerve signaling, and the vagus nerve goes from the gut to the brain, that could otherwise trigger glial cell activation and promote neuroinflammation, which would make the hypersensitization worse. Moving into our first of 3 supporting case studies called A Systemic Review and Meta-Analysis of Nutrition Interventions for Chronic Non-Cancer Pain. The purpose of this study is a systemic review evaluating the impact of nutrition interventions on participant-reported pain severity and intensity in populations with non-cancer chronic pain. Methods included 8 databases being searched for full-text research study published between the dates of 1980 and December of 2017, which included adult populations of 18 or older with chronic pain, a nutrition intervention, and a measurement of pain for evaluation. There needed to be something to quantitatively measure for pain values. PRISMA guidelines were followed for systemic reviews and meta-analyses. 4 reviewers independently assessed the risk of bias using the Academy of Nutrition and Dietetics criteria checklist. 7,080 studies were initially identified in the search. 71 studies were pooled after completing the full text screening. And then lastly, 23 were eligible for the meta-analysis. Limitations to this study included pain being self-reported. Obviously, that's subjective to each person, so based upon the sensitivity, they could score higher or lower. Diet adherence can vary between each person. External factors like past trauma or injury, lifestyle habits, activity level, sleep hygiene, and mood can affect pain levels between each person. And many studies are done on single population groups with small sample sizes. Going through the first case study's results, participant characteristics ended up looking like population sizes being very large, between 12 people and 2,121 people. Sex was mostly a mix between females and males, although there were a few that had specifically just females. Ages ranged between 33 years old and 66 years old. BMI was between 18 and 36, with the majority of the adults having an overweight BMI. Diagnosed pain conditions included osteoarthritis, rheumatoid arthritis, fibromyalgia, diabetic neuropathy, irritable bowel syndrome, chronic pains, low back pain, and joint pain. Outcomes that were measured included stiffness, pain severity, joint tenderness and swelling, function, and blood CRP levels. The nutrition intervention types were the 4 major ones: altered overall diet, altered specific nutrients in the diet, supplement-based interventions, and then fasting therapy. So the overall altered diet showed that 12 out of 16 studies had some significant improvements in reported pain. So that was the most impressive one, showing that you don't have to have these super strict diets. You don't have to completely change everything. Just overall improving more plant-based whole foods, having more colors, having more lean proteins, having more fiber. It's really helpful. It makes a huge impact in chronic pain. Altered specific nutrients showed that 2 out of the 5 studies found a significant decrease in reported pain. The supplement-based interventions found that 11 of the 46 studies found significant decrease in pain. And then the fasting studies, 1 of the 4 studies found a decrease in pain, but the fasting was not significant as a treatment for alleviating pain itself. It showed improvements, but it wasn't a huge significant difference. Take-home point includes all 4 nutrition interventions did lead to pain reduction, with fasting therapy being the least helpful, and the altered overall diet intervention having the largest improvement, 75% improvements for pain levels. Second case study is called Food Pyramid for Subjects with Chronic Pain, Foods and Dietary Constituents as Anti-Inflammatory and Antioxidant Agents. The study reviews current research on dietary strategies and nutrient interventions for managing chronic pain, and then constructs an evidence-based food pyramid based upon the findings to recommend an eating pattern for patients of chronic pain. Methods utilized were databases like PubMed, National Center of Biotechnology Information, and the National Library of Medicine of Bethesda, USA, to find studies by using the following key search words like chronic pain, foods, inflammations, oxidative stress, and nutrients. narrative review included 172 studies from varying intervention topics, which included olive oil, legumes, various spices, fiber in general, eggs, meat varieties, specific vitamins and minerals, and then other foods. Limitations within these studies were that there are currently no randomized controlled trials in humans regarding nutrition interventions for chronic pain. The study relies on a narrative review rather than a meta-analysis in general. Anti-inflammatory effects and potencies for the isolated nutrients in the lab studies may not be the same when consumed in whole foods or a diet. So for example, say you consumed 100 milligrams of a specific nutrient, you can't just guarantee automatically that a food that is rich in that vitamin is going to give you that exact same amount to the exact measurement of 100 milligrams. And then chronic pain is multifactorial. So there's factors like diet, lifestyle choices, physiological factors, biomechanical factors, altered neural pain processing, and other things that need to be considered in combination with just the chronic pain and the nutrition in general. The results of the second case study include the following. You will see the food pyramid on the right. Also, you will see the recommendations. So there was daily and weekly consumption recommendations. So daily, people are recommended to consume 5 portions of fruits and vegetables, 3 servings of low glycemic carbohydrates, which would be like quinoa, brown rice, sweet potatoes, etc. 1/2 cup of Greek yogurt, 1/2 cup of red wine, and then extra virgin olive oil, using that for your salad dressings, for cooking, etc. And then weekly consumption, so things that you would want to incorporate in a weekly meal plan, would be 4 servings of legumes and fish each, 2 portions of white meat, so turkey, duck, chicken, etc., eggs, and fresh cheese. So you'd want to have 2 portions of white meat, 2 portions of eggs, and 2 portions of fresh cheese, whereas you'd want 4 servings of legumes and fish. And then 1 serving a week of red or processed meat, and then sweets on occasions. So not saying you can never have that processed meat like brats or sausage or cookies for sweet treats. It's just having them more on occasion. And then also noting that vitamin B12, vitamin D, omega-3 fatty acids, and fiber supplementation can be helpful to improve outcomes as well, in addition to these general nutrition recommendations. Big take-home point from the second study would be a diet rich in fiber, anti-inflammatory fats, colorful fruits and vegetables, fish, plant-based proteins, olive oil, and low glycemic carbohydrates may help reduce chronic pain and ease the side effects, which is usually constipation, for the pain management medications. Additional supplementation of specific nutrients like B12 and D, omega-3 fatty acids, and fiber can also be helpful for boosting those dietary changes. The third and final research study is called Weight Loss, the treatment of choice for knee osteoarthritis, randomized controlled trial. The purpose of the study was to assess the effectiveness of rapid diet-induced weight loss on the function of obese knee osteoarthritis patients. So specifically patients that have osteoarthritis as their pain condition and have a BMI categorized as obese. Methods included it being an 8-week randomized controlled study. Body weight and composition were measured at the beginning and at the end of the study. Population for the study was 80 osteoarthritic patients, 89% of them being women. The mean BMI being 35.9 and mean age being 62.6 years old. Changes in body weight and composition were examined as independent predictors of change in the symptoms of knee osteoarthritis. The symptoms of osteoarthritis perceived by patients were assessed by the WOMAC Osteoarthritic Index, which is an osteoarthritis specific questionnaire that addresses severity of joint pain, stiffness, and limitations of function. Also, the visual analog scale was what was used to assess pain levels. Inclusion and exclusion criteria included inclusion being overweight BMI greater than 28, adults being 18 years or older, having a primary knee osteoarthritis diagnosed according to the American College of Rheumatology. Exclusion criteria was having a history or active presentation of other rheumatic diseases that might be responsible for secondary osteoarthritis, diabetes, endocrine disorder, or substantial abnormalities in renal, hepatic, or hematological function. More information includes population information. There were two different groups, the experimental group and the control group. Experimental group had a low energy diet with only 820 calories per day, which is a very low calorie diet. They didn't get to eat food. They drank nutrition powder shakes dissolved in water 6 times a day. So they had 6 small meals in a sense, but those meals were protein shakes or meal replacement shakes. The macronutrient breakdown of those shakes were 37% protein, so pretty high protein, 47% carbohydrates, and 16% fat. They also received nutrition therapy, so one-on-one counseling with a dietitian for an hour and a half each week, which is very helpful for sustainable behavior change. The control group got a general conventional hypoenergetic diet, high protein, and was under 1,200 calories. So as long as it was a high protein diet and they had 1,195 calories a day, it worked. They also didn't receive one-on-one counseling, but they got a 2-hour single presentation by the same dietitian and were provided an example booklet for meal plans. Strengths of this study were that the same registered dietitian was used within both cohorts. The low energy diet group all drank the same meal replacement shakes to keep the diet consistent. And then both diets, whether it was experimental or conventional, since even though they were low calorie, they both were high protein diets to help mediate and prevent muscle loss during the low calorie diet. Because it is very common if you're that low in calories that you will unfortunately lose a little bit of muscle mass. Limitations of this study were the control group was able to eat any diet if they stayed within the calorie amount and it was high in protein. So, I mean, they weren't necessarily only eating anti-inflammatory fats, colorful fruits and vegetables, high fiber foods. They could have really been eating anything, which could still lead to some inflammation and could lead to poor ultra-processed food choices. Control group only got one presentation and an educational booklet in comparison to the low energy diet experimental group getting weekly nutritional one-on-one counseling sessions, which is obviously helpful for behavioral changes and staying more accountable and consistent. And then symptoms and pain intensity are subjective to participants, so that was provided independently. And then both in general are very low calorie diets that increase chance of muscle loss and are when you lose weight. Because when you lose weight, you can lose muscle mass, you can lose water weight, you can lose fat. We want to hope that most of it is fat, right? So increasing your protein consumption and preventing it being from like a super drastic calorie deficit are the most important ways to help maintain muscle mass. I'm going to premise that a 1,200 calorie diet is still fairly low. 1,200 calories with really healthy foods is a very low calorie, like healthy diet that is sometimes given to people in bariatric programs. But an 820 calorie diet, specifically with only having protein shakes or meal replacement shakes, is very restrictive and very, very unsustainable. Results from the third case study included 81 of the 109 participants completing the full 8-week study, which is still a good amount. Of people that completed the full study, the average age was 60 years old, the average BMI was 36, and they on average had 44 pounds of excess body weight. So some had more to lose and some had less to lose. Outcomes were, although there was a weight reduction in both groups, so both groups did lose weight, the low energy group, which was the one with around 800 calories a day, and they had the 6 meal replacement shakes, they lost 14.5 more pounds and 6.8 more body weight than the control group. That group also lost 2.2% more body fat than the control group. For a body composition change, like I said, you can lose fat, you can lose muscle, you can lose water weight. You ideally want to lose fat. The number of patients achieving greater than 5% weight loss for both groups was, for the experimental group was 92.5 and the control group was 25. The number of patients achieving greater than 10% body weight reduction, so say you were 300 pounds, you lost at least 30 pounds. For the experimental group, it was 50%, and for the control group, it was 0. So no one in the control group lost more than 10% of their body weight. And then patients on the experimental diet showed a significant improvement in knee osteoarthritis symptoms based upon the WOMAC score, while those on the control diet did not, with a clear difference between the two groups at the end. Also, the LED diet group showed a significant improvement in stiffness, while the control group did not show an improvement in stiffness. The take-home point from all of this is that a simple weight loss intervention can lead to a significant improvement in physical function and pain experience for obese patients with knee osteoarthritis. Like I said, I'm going to premise as a dietitian, I generally would not have someone eat 800 calories and no food, right? That is not something that's really sustainable, and it's not something that I think would be maybe realistic. But that being said, it does prove a very good point that being a healthy weight in general, if you are overweight or obese, losing weight to get your body into a healthy weight, or just losing at least 5% of your body weight in general, improves your body function and your pain. So that's a very important thing to take away from this study. So the overarching nutritional intervention goals for chronic pain management for dietitians as part of the healthcare team would be to increase consumption in patients for fruits and vegetables, since they contain phytonutrients and antioxidants, which decrease oxidative stress and inflammation. Also getting patients to eat more fiber-rich, low glycemic carbohydrates, which provide a slow, sustained energy without leading to a large blood sugar spike, and provides gut-healthy prebiotics in addition to modulating inflammation. Having them eat more lean proteins to build strength and muscle mass to address the deconditioning that occurs with chronic pain, and provide important micronutrients associated with proteins, a lot of B vitamins. And then omega-3 fat sources, because they reduce inflammation and oxidative stress while improving pain sensitivity. And those would be fatty fish like salmon, tuna, sardines, nuts and seeds. So walnuts are very high, chia seeds, flax seeds, olive oil, avocados, foods like that are very rich in omega-3 fats. Limiting added sugar and ultra-processed foods in general prevents the inflammation and oxidative stress associated with those foods. And lastly, staying within an appropriate calorie limit. So eating, whether that's associated with, 1,500 calories, 1,600 calories, whatever the dietitian chooses with that specific patient, eating within your appropriate calorie limits and trying to maintain or get to a healthy body weight in general. Overarching take-home points for nutrition with chronic pain is an anti-inflammatory Mediterranean-styled eating pattern, prioritizing colorful plants like vegetables, fruits, legumes, nuts, and seeds, lean proteins, omega-3 fat sources, and fiber-rich carbohydrates are the ideal way of eating to improve chronic pain. Staying a healthy body weight or BMI is very vital. If a person cannot get the right nutrients through diet alone, supplementation of specific nutrients can be helpful, such as omega-3s, B vitamins, vitamin D, etc. Nutrition should be accompanied by other lifestyle changes like healthy sleeping patterns, exercise, hydration, and stress management as well to control chronic inflammation. Registered dietitians should be part of the chronic pain management team for all patients to optimize health outcomes due to their specialization in nutrition, psychological behavior change, supplements, and other lifestyle considerations. Now looking at future direction and clinical implications. Fortunately, under a lot of insurances, medical nutrition therapy is not covered for chronic pain. So figuring out how we can have more affordable, maybe cash-based options, or advocating policy-wise for more insurances to cover patients' nutrition interventions for chronic pain. Also, financial, environmental, geographical, and cultural differences need to be considered when working with patients. For example, is there a language barrier? Is there a certain way that patient eats for ethical or cultural reasons? Whether that's not eating certain foods, or it's following Hispanic traditional cuisine or an Asian cuisine. If they don't eat pork, things like that. Outside of that would be financial, right? So outside of cultural, it's what's affordable for this person. Yes, we can have this ideal thing of let's eat salmon 4 times a week. But if that person can't afford that, how can we also get those healthy omega-3s into their diet? Maybe through walnuts, or maybe through olive oil, some chia seeds. Those might be more affordable than getting salmon, getting some canned tuna, etc. There's different ways that we can focus on getting specific nutrients into our bodies to get the proper outcomes and benefits that might have more financially affordable food options. Also, supplements might not be financially realistic for everyone either. Those can be expensive. So that might not be something to help boost the diet for a specific patient, and that's okay. So they were going to have to focus really, really hard on staying specific to their diet plan because they aren't going to have the opportunity to buy extra supplementations to boost it. And then geographically and environmentally, we just have to consider, okay, do these people have access to these locally grown foods? Do they even have grocery stores within 5 miles? Are they in a food desert? What do they have access to? So there's a lot of those things that need to be considered that dietitians can help patients work on and consider all of these things when making an appropriate diet plan. Another thing would be educating other entities within the healthcare system about the importance of nutrition therapy within chronic pain management. That'd be physical therapists, physicians, exercise physiologists, occupational therapists, nurses, etc. A lot of people, not to their own fault, just don't know that nutrition really is impactful with chronic pain due to the fact of how much it can control inflammation. So just educating people on that is very helpful. There needs to be more dietitians that are out there advocating, at lunch and learns or at conferences that incorporate different providers like this conference to say like, hey, this can be part of the equation and here's why it's beneficial. Another thing to be considered would be behavior change is also usually very challenging, which makes adopting dietary and lifestyle improvements difficult for patients, which underscores the importance and critical role dietitians play in supporting that sustainable behavior change to get the outcomes patients are looking for. Lastly, a comprehensive, holistic approach that addresses sleep, mood, physical activity, self-talk, and stress, and many other things is essential for patient long-term health and success overall. Whether they're trying to work on chronic pain, diabetes, lowering their blood pressure, whether it's anything, looking at patients in a holistic, comprehensive way is going to have the best possible outcomes for the patient, the healthcare system, and the providers themselves. The next 2 slides are my works cited. I want to thank all of you for watching my presentation, and I really hope the information I gave you today does just help spark conversation within your healthcare systems with friends, family, whether it's patients who have chronic pain or coworkers that work with you in a rehab setting, or providers that work with orthopedic patients or chronic pain patients. Getting conversations going about how nutrition and healthy lifestyle habits can truly be impactful in a very realistic and modifiable way to have beneficial outcomes for patients of chronic pain.